Welcome to Choose You First, a self-direction podcast by Public Partnerships. On today's episode, we have the godmother of self-direction herself, Suzanne Crisp, where she and I discuss what is participant direction. We then dismiss a number of the myths around the model and then go around the country talking about states that are getting it right. Suzanne did an excellent job explaining the benefits of the model from the person standpoint, I think. From a human standpoint, most of the discussion ends up being around Medicaid and dollars and cents. Number two, I think she gave some clear guidance to states on how to administer the model at a high level, and then also gave individuals some good advice on how to learn more about what participant direction is. And then finally, in her wrap-up question, I think did an excellent job in describing all the benefits there are to working in the social services, to investing in a career that gives back to others, and the value and the reward that it's brought her over a 30-year career was pretty well stated at the end, because we need more Suzanne Crisps in long-term care for sure. And without further ado, here is our podcast with Suzanne Crisp. We hope you enjoyed as much as we did. Thanks for joining the podcast today. Appreciate you. And let's start at the beginning, Suzanne. How did your journey lead you to become what many of us, including myself, have referred to as the godmother of self-direction? What sparked you to want to get into this stuff?
Well, thanks for asking that question. I've also been called the grandmother of self-direction, and I much prefer godmother.
We're elevating your status. Yes.
I know. So let me tell you a bit about my history. I was the assistant director to the Aging and Adult Services division at the Department of Human Services in Arkansas. And we were always looking for things to expand our innovations. Arkansas is a poor rural state, and we're not known for our progressivism. But I wanted to change all that with Medicaid. I knew there was great possibilities. So a grant opportunity came out. It was called the Cash and Counseling Demonstration. And this was sponsored by the Robert Wood Johnson Foundation and the U.S. Department of Health and Human Services. And what the grant wanted to do was explore what happened when people were given the resources and allocations that for their care, what they would do with managing their own services and supports rather than receive services from an agency. So it was a lofty goal. New Jersey, Arkansas, and Florida were chosen as the experimental states. Cash and Counseling has now been called one of the most successful social experiences in the nation. And let me tell you why. We had a treatment and control group. In other words, part of the people who wanted to self-direct were able to self-direct. Part of the people that didn't want to, that wanted to self-direct, had to stay into the control group and receive traditional services. So, and Mathematica came in and compared the outcomes of both of those groups. They compared satisfaction. They compared service access. They compared high utilization, the amount of personal care used. So it compared a lot of different things. And so I was in Arkansas. Arkansas was the first to implement the self-directed model. We were the first to meet our enrollment goals, and our the findings of Cash and Counseling were mostly attributed to the findings in Arkansas. So I got my start there. And then I went, partially because of the success of the cash and counseling program, the federal government Centers for Medicaid and Medicaid Service, Medicare and Medicaid Services asked me to come and help roll out a national agenda for states. States had heard the very positive findings of cash and counseling, and so the federal government said, "Well, maybe we need to start, allowing people to self-direct." So I went to Baltimore and worked at CMS for a couple of years, and we rolled out the national agenda for self-direction. And that national agenda was one that required person-centered planning. Back, in early 2000, person-centered planning was just emerging. So it required person-centered planning. It required people to have the authority to hire their own staff, so long as they met minimum qualifications. We also allowed people to have budget authority. And what this means is that they were allowed to have permissible purchases for items and services that enhance their well-being. For example, if you bought a person a microwave, their reliance on human assistance was reduced. So CMS developed, it was initially called the Independence Choice Program, but eventually it just evolved into adding self-direction to 1915C waivers, home and community-based service waivers. So we rolled that out, and then along came the systems change grants, and a lot of states use their system change grants to implement self-direction. So I was part of a team that provided technical assistance to those states through the grants. Then I went to work for the Center for Participant Directed Services at Boston College. And now I work for Public Partnerships, and we are doing good things out there by implementing solid programs. So I think that's why, just because I've worked on various different levels, I think that's probably why they call me the godmother of self-direction.
Perfect intro, Suzanne. So there's this new model. In Arkansas, it was independent choices. Behind, I think you'd agree, a new concept emerging, which is let's give folks, and you noted for rural areas, I want to come back to that a little later, but more choice, more control, more self-fulfillment. I feel like a higher quality of life. And we start terming this as you mentioned, participant direction in some states, consumer direction in others, self-direction in others. Other states follow in your footsteps. They try some pilots. Some states seem to embrace this concept of allowing individuals more choice and control over services more than others. And we fast forward to 2023, and we're at about 1.5 million, 1.2, 1.4 million people. Mm-hmm. 33 years later. And what do you think as far as overall that number of people using the model? Has it met your expectations and projections? What do you think on that as far as the national adoption of the model at this point?
Well, at the time in 2000, we were just hoping to get our pilot programs off and running. And what we had hoped is that maybe 5% of the population would select self-direction. And that has actually played out now we find between 10% and 15% are adopting self-direction. So let's look at some of the reasons why it has not grown so big. First of all, there's an overall cultural assumption that when you give people their allowance or cash, that they're going to misspend it. They're automatically going to spend it on things that are potentially illegal, and
Can I
not
stop
take.
you there for a minute and just
Yeah,
say, so what you just said, but the Robert Wood Johnson Cash and Counseling pilot, 3 different states, bared out all those years ago that didn't happen. But it's
no.
so interesting, right, Suzanne, that the narrative persists
Hmm. Hmm.
despite a very soundly run pilot all those
That's
years
right.
ago. But
That's
please
right.
continue. Yes, it does continue.
So I think it's discrimination against poor people too. If you give poor people, uh, access to resources, then they're going to misuse them, and that's a cultural issue that we need to deal with. Um, but another misconception is that people said, particularly the Aging Network, said, well, this is fine for people with physical disabilities, young people with physical disabilities. And it's not right for elders. It's definitely not right for individuals who have developmental disabilities or intellectual disabilities. And all that was proven wrong with the uh, demonstration program. We found that elders loved the program and that they flocked to the program and really wanted to, hire people that they knew and trusted. We found that during the pandemic, people didn't want workers coming in who had just gone from another uh, client to come into their homes and provide them with intimate care. So some of the cultural issues are still lingering out there. There's also the issue that if you give that if a state develops a self-directed program, that it's going to be full of fraud and abuse. And there was an Office of Inspector General report that came out that said that self-direction was wrought with fraud and abuse. And when we asked them about how in the world did you get that information, because we're not seeing it practice in reality, they said, well, we made the assumption that this would be fraught with fraud and abuse. To tell you the truth, there's been very, very little fraud and abuse detected, none in cash and counseling. And a little bit over time, we've seen some workers and participants enter into agreements where they didn't provide the care, but were paid anyway, and then the participant and the worker split the money. There are a few instances like that, but it's not nearly so bad as what agencies are doing with personal care and the fraud and abuse that exists there. Another issue was that Medicaid directors said that, well, if we have self-direction, this is going to cause people to come into the Medicaid rolls, and then we'll have enormous enrollment figures, and it would be we just can't afford to have people on this many um, roles. Sorry. But what we found is that roles have increased, but not due to self-direction. It's more medical need. And people are getting older, they're getting sicker, more people with chronic illnesses, more people with developmental disabilities. So that hasn't proven out. Another thing that CMS has required is that there be a support system around self-direction. And this is somewhat of a complex support system. CMS says that you have to have a financial management services entity, and that vendor would be the responsibilities would include processing payroll, enrolling people as employers, enrolling workers as employees. So, and that's what PPL does, Public Partnerships does. There has to be that structure in place. Another required support system is information and assistance. We found with cash and counseling that there had to be somebody that explained self-direction talked about the responsibilities, made sure that individuals had the capacity to self-direct or at least appoint an informal representative to help them. So states have had to develop these two new systems in their states, and that has been is somewhat of a challenge. Enrollment takes a long time to process all of the paperwork. And this is because of, Department of Labor laws and regulations and IRS laws, regulations, criminal background checks, drug testing, I-9s to verify citizenship. So there's an awful lot to process a person as an employee, and it does take time. I can go into a nursing home tomorrow and start receiving payment. So
I also think it's true that the information technology systems in every state that are required to move all of these Medicaid service dollars are in large part from the 90s, some as far back as the 80s. And what we found in a state like California is the supporting information technology for individuals' Medicaid budgets and the attached service authorizations for their services cannot handle self-directed models well. And so there are process hangups stateside that often impact how long we can just get the services authorized. And you put it all together in an environment where folks clearly need services as soon as possible. And traditional agency seems to continue to be the quickest path. However, it's not the most stable one, as we know. Suzanne, as you and I go around the country, we're hearing about workforce shortages upon workforce shortages, whether it's in nursing facilities where some of our elders are placed, or it's in home care agencies due to the reasons you outlined and certainly accelerated after COVID-19. It seems like this self-directed model needs a second look by a lot of folks. Would you agree with that?
I would certainly agree with that. With self-direction, you can hire friends and family, neighbors, someone from your church. You can hire several different people, like a couple of neighbors. One comes in the morning, one comes in the evening. One helps you out of bed in the morning, and one helps you into bed in the evening then. So it expands to a non-traditional workforce. I myself would not go to a traditional provider agency, home health agency, or personal care agency and say, I'd really like to work here. I'd like for you to employ me. Whereas I am willing to take care of my mother. So it becomes a very, very personal thing. So it markedly expands the workforce. We found this to be true during the pandemic. There were 23 states that asked the federal government for temporary modifications to their program in order to get people in the home. One was the ability for them to hire legally responsible relatives. And by this, I mean spouses and legal guardians and parents of minor children. 23 states requested these modifications to hire those individuals. And many states have modified their waiver applications to include hiring legally responsible relatives. So this even expands the workforce tremendously. Another thing during the pandemic we found is that in order to gain access to services, immediate access to services, that the qualifications of a worker were you could hire a person conditionally. And what that means is that an individual could be hired and they could process the background check and do the required trainings and do other things through the application process, but still be paid to provide services. So that was really instrumental. I think self-direction expands the workforce markedly.
Sure. And we saw recently the administration on community living put out a national strategy to address the unpaid caregiver uh, crisis or issue, as we recently heard last week at a national DD conference, that really we've had a number of long-term systemic failures resulting in now unpaid family caregivers delivering hundreds of billions of dollars of unpaid care each year, with workforce shortages and those unpaid caregivers having their own economic stresses. And in fact, Suzanne, you and I were at the National Councils for Developmental Disabilities conference last week and heard personal stories of family members needing to quit their jobs in order to provide care, and in the process creating personal economic hardship,
Mm-hmm.
family economic hardship. So it was great to see 23 states are make changes during COVID. Are there a few states in your opinion that are doing participant direction right? And what do you think contributes to that, or what are some of the factors that make you think we should all be doing it like these few states?
Okay. Well, I've been giving technical assistance since about 2003. A long time, 10 years, 20 years. Oops.
Yep.
And what I have
Goes by
found,
like 10, but in
yeah,
fact, it's 20.
and dog years, yeah. Um, so what I've seen is like every self-directed program. I've either read the waiver or provided the program with technical assistance through CMS contracts. So I've looked at a lot of programs. One program that I really like is, won't surprise you probably, but I like the Arkansas Independent Choices program. Now, when I left the program, we had a healthy enrollment. There was about 5,000 people enrolled in the program. But since that time, roles have dwindled. And we're just now getting into why roles are dwindling. But I know the state is really adamant about ensuring that self-direction grows. But I like the Arkansas program because it uses a 1915J Medicaid authority. And what that authority means is that you can provide self-direction in your state plan program, your personal care state plan program, and your waiver program. So you can have an infrastructure that serves both of those big Medicaid service areas then. You can have one FMS or a few financial management services, and you can have one entity that provides information and assistance. So there's economy and scale there. Another reason why I like so as far as using the 1915J, the population expands who could self-direct. Another reason why I like the Arkansas program is that they have a robust list of permissible purchases, and they are very flexible. And anything that would enhance the independence of that individual could be considered a permissible good or service. Arkansas also allows people to save for a particular item. So if a person wanted to save for a microwave, they could put some of their individual budget amount into a savings account to save up for things. They also provide about 10%, I think, for discretionary money. In other words, if you want to take an Uber ride to the mall, and enhance your community integration. You could do that in the Arkansas program. I think there's a lot of room for growth and for greater expansion with the Arkansas program, but I do like at least the design of the program because it provides the most flexibility of any self-directed program. Another program that I really like is the ISIS program, the IRIS program in Wisconsin. This program is a self-directed program, and again, it takes the philosophical foundation of person-centeredness and self-direction and the flexibility and control that is offered through self-direction. It takes that to the next level, and it really supports the philosophy of self-direction. Another program that is that I like is the New Jersey program, which was an original cash counseling state. New Jersey's growth has been phenomenal. Over 30,000 people are now self-directing in New Jersey. And back when it was a beginning state, there were only 2,000 people. So those are really good services. But the nice thing about building a self-directed program is that CMS helps you do that through, there's an Appendix K in 1915C waivers, home and community-based service waivers that will that ask you questions that you have to answer, and that in and of itself then helps you design your program and with deliberation. Also, promising practices of other states will help a state and program develop a solid design.
Got it. So obviously, you and I are proponents of the model, see all the value in it, and I want to jump back to some of your earlier comments, and let's you and I play the role of devil's advocate here and echo some of the concerns that we hear about the model, and let's you and I unravel a couple, if you will. And I would like to start with Medicaid fraud, waste, and abuse. And so for our listeners, Suzanne and I receive annual Medicaid fraud, waste, and abuse training. Oftentimes, fraud, waste, and abuse are all thrown together as a singular term. There's three different things going on. Let's start with waste and abuse and come around to fraud, which seems to be the one that is always the focal point with self-direction. Medicaid waste would be an instance where Suzanne Crisp is authorized for 64 hours of attendant care per month, which is about 14 a week or 2 per day. Just 2, I want to make it clear for our listeners. In the Arkansas Independent Choices program, the average individual has been assessed and determined to need a couple hours a day of support with their assisted daily living activities that include getting dressed, meal prep, completing tasks around the house that you and I take for granted. That's what we're talking about in most self-directed models. A pretty limited number of hours to help with assisted daily living activities. So coming back to how could that authorization for services, which in Arkansas equates to about $20,000 a year, $22,000 in Medicaid funds. Not a whole lot, Suzanne, because the wage payable is around $11 an hour.
Mm-hmm.
So these are not high wage employees. And so waste would be Suzanne is only using 6 of those 14 hours every week. And this has been going on for a year. And meanwhile, those Medicaid dollars could have been spent on someone else. Therefore, Suzanne could be underutilizing her services, and that could be considered waste. I think we would agree, Suzanne. However, The financial management service provider that you've referenced is responsible for reporting to the state on a monthly basis all individuals' utilization rates on services. So, in fact, both the state and the FMS can address those that are underutilizing. So, there is a clear example of how we monitor waste. Let's jump to abuse. Abuse would be Suzanne is submitting for 15 hours of care in a week when she only has 12, and she's using all her monthly hours before the end of the month. I would consider that abuse of Medicaid dollars, because she's then creating a situation where Medicaid has to spend more money on her if she falls and hurts herself, where a care attendant is not there. Again, the FMS reports utilization for overutilizers as well to the state. So, without going too far down those holes, there are mechanisms in place for both the state and the financial management service provider to monitor through data and reporting things like waste and abuse of Medicaid dollars. Now let's come around to fraud, Suzanne, our favorite one. And you referred to it earlier, that there's classism in the system. There 100% is. There are stigmas that if you give low income folks anything, and they're not getting cash, they're not getting Medicaid dollars in their hand, they're simply getting authorized for attendant care services to be delivered in their home. It seems like the biggest critique on this model is the attendant doesn't actually show up and even provide the care, and they split the money, as you alluded to. I guess that would be the scenario. So, can you talk a little bit about electronic visit verification, Suzanne, as far as helping to increase our visibility that the direct care worker actually did deliver the service? And you don't have to go high level, but
Right. Before I get to that, I would like to say that there is that Public Partnerships is working on a white paper now, and it talks about quality management and self-direction. So, love to share that. It'll be on
super.
our website when it's done. Some other strategies to help with fraud and abuse issues is to inform participants as well as workers about what the consequences are of misusing funds, and particularly intentionally misusing funds. That you can be, self-direction will disappear and you'll have to go back to the agency services. So the worker and the participant have to understand what the consequences are. They also have to understand what fraud and abuse is, and that's part of the thing that information and assistance provides. Um, having monitoring oversight strategies, which will be part of our white paper, are very, very important. So there are quality strategies that you can put in place to help monitor fraud and abuse. And of course, the financial management services has a very large role in fraud, waste, and abuse. But the electronic visit verification system is part of the 2021 Cures Act. And what this law says is that we think that there's fraud and abuse by agencies and self-direction when people don't even show up at a house, but yet they get paid for providing services. So what the electronic verification system does is requires a worker to come into the home and they clock in, and their location is identified so that we know where they are. And then they provide various services that they note, and then they clock out. And this is all electronically managed. And the purpose of the Cures Act was to eliminate fraud, waste, and abuse. So it's somewhat problematic, particularly in rural areas. If you
Can
don't,
I poke the bear for a minute? I was going to say it
yeah,
was introduced through the Cures Act because of agency provided fraud.
Okay. Okay.
No, not because of self-direction fraud. Now,
Hmm.
self-directed programs are needing to follow suit because
Right.
the agency providers were upset about this. But to bring this full circle, CMS had to introduce a geo-tracking
Hmm.
system called electronic visit verification because of the fraud in home care
Okay.
agencies.
Yeah. Okay. Yeah.
And
Good point. Good
the
point.
irony that you and I have to defend self-direction with EVV, it was never an issue over here, actually. It
Okay.
was an issue because the OIG put out an audit on the Veteran Health Administration's Homemaker Home Health Aid program and found $150 million of completely unsubstantiated care,
Hmm. Hmm.
equivalent of care delivered in homes. And so, yeah, to the fraud, waste, and abuse, it's actually more because of big Medicaid provider players like home care agencies
Right.
committing fraud that is at large scale and not the participant directed models. But you
Hmm.
were just getting to a point I'm glad you're going to get into a bit, because I would like to spend a few minutes on the rural population. You were saying EVB is obviously, given that it's phone app driven and technology driven, is a challenge in rural areas.
Hmm. Hmm. I think there are a lot of, and thanks for bringing up the point. It was not self-direction fraud; it was agency fraud. So the electronic visit verification we refer to as EVV, and it there's a lot of challenges to that, particularly in rural areas that where there's no access to the internet. So we've had to develop some workarounds there. And Mark, you can probably talk more specifically about that. Another challenge is that not everybody has a smartphone. Not everybody knows how to use a smartphone. A lot of times people just are really intimidated by electronics using their smartphone. Um, Other challenges is, it just basically understanding the technology behind everything, um, and sometimes losing power. And again, there are a number of workarounds that probably you can talk about better than myself.
Yeah, there are telephony options for folks, but at the core of it, um, I'm not a fan of it for self-directed models, and I don't think it was intended for them. And I think it is another barrier to getting into self-direction. And you've talked about a number of the timelines involved, but let's talk for a minute about being rural. And
Mhm.
so, what we're and shall see more of in 2024 as I think CMS and managed care organizations start to demand it from their in-network providers of all types is we have workforce shortages. They're impacting all types of Medicaid service providers, including in-home care attendants. And most most directly, it seems like through data that I've seen, and not surprisingly, rural areas, because you already had a limited number of home care agencies to supply rural areas with in-home care. Now, post COVID, we're seeing the length of time that an individual gets referred for home-based care and actually getting a care attendant get longer and longer across the board, but more so in rural states. And this is a piece that, do you have any thoughts on how we can try to engage state administrators to focus on solving some of the rural workforce shortages through self direction? I think it is very challenging. But you're the godmother, and we have you today with a captive audience. So
Sure.
um, I don't expect you to have the solutions, but a state like Arkansas, which is both your home state and home to a good self-directed model, is home to large areas of rural,
Mm-hmm.
some of them highly rural. And I think it's a challenge we'll be looking to solve in that state, along with the state.
You've been.
But it's a tough one.
Yeah. Well, first of all, self-direction really helps to the access issue in rural areas because you can, using an agency, they would have to drive sometimes 30 miles, half on a dirt road to come down. So agencies were not keen on sending people out to very rural frontier areas. So that's where self-direction comes into play. You can hire somebody down the road or over in the next town to come and help you with your bathing, dressing, grooming, items like that. So self-direction is good in rural areas, and we've had some success with that. Some of the challenges in rural areas is finding people that they're able to hire, individuals that would be able to serve as workers. The population is sparse sometimes. So that's certainly a challenge. Rough roads in roads that are undrivable are also issues out there. I think the states could do a better job in outreach to rural areas about self-direction. Sometimes these people are very, very isolated, no television, possibly a radio or something, but they don't go to town much and hear talk about new Medicaid programs. They just don't hear that. So I think states could do a lot better job in outreach in rural areas. They also could do some comparisons of underserved areas, like, compare the 150% poverty level with the number of people who are on Medicaid and identify underserved areas that way, and then have a targeted outreach for those particular areas. So lots of things that could be done. Word of mouth is wonderful. If we could set up peer groups that would help people understand, people who were receiving services themselves, if we could set those up and have some sort of communication, if it's available in the home, and some of these homes have electricity and water, and that's about it. So I think we could all do more to identify underserved people.
Great stuff. So I'm sure at this point in the program, after about 40 minutes, any listener of this podcast is very intrigued. And my guess is that a number of them are hearing about participant direction for the first time. And so let's go around the horn of potential listeners of this podcast. And you talk a little bit about what they could do, broad stroke, to learn more. So we could have an elderly or physically disabled person listen to this podcast and wonder, wow, I wonder if there's any options for me to self-direct in my state. And can you just say a few words about whether it's the AAAs, the SIL, some of the major players that sometimes fill that role in order to help a listener today who's aged or disabled learn more about what's available in their state?
Okay. Great question. So some of the things that a person can do to learn more about self-direction is to go to our website at publicpartnerships.com. And there are lots of stories on our website. There's an introduction to what self-direction is and what consumer direction and participant direction mean to people. So I would suggest that they do that. If a person is on Medicaid, they could go to their local county office and say, I want to learn more about self-direction in my area. Can you tell me, am I eligible? Can I receive state plan personal care? Can I be admitted to a waiver? So they'd go through kind of an eligibility process then. Certainly, area agencies on aging serve as the advocates for the network. So, contacting an area agency on aging might be a good resource to use. The adult and disability resource centers that are administered from the is also a place that they can go and get more help. Probably the single most knowledgeable place is going to be Center for Independent Living, since they were instrumental in bringing self-direction to the forefront with persons with disabilities. So I think those would be some great resources to follow, but certainly looking at our website would be a good place to start.
Perfect. Perfect. You and I meet a lot of state administrators, and we talk to them for 5-10 minutes about everything you've said on this podcast, and they tell us, we wish we were doing more with self-direction in our state. Could you give any state administrator overseeing their long-term supports and services, if you wanted to do more pretty quickly, here's a couple things that you could do. Could you fill in that blank for us?
Sure. I think, first of all, they need to look at their own systems and see how healthy they are. Do people have access to services? Is self-direction well defined? Does the state support that? What does it say in your Medicaid waiver about self-direction? And what it says is that really being done? There's in Appendix E, there is a lot of questions that CMS asks states to complete, and so look at that and see: A, is it thorough? B, is it accurate? We find a lot of states have things in their waivers that they're really not doing. One state said that they had budget authority and they never implemented that. So they're really out of compliance with their waiver. So look at your own waiver and look at your own systems. How long does it take for a person to have access to self-direction? Does it take 30 days? Does it take 90 days? Do we even know? So it's looking at the health of your own system and then identifying places where you might improve things. And I know that states can get free technical assistance through CMS. What you would want to do is go to cms.medicaid.com and then look to see about resources for obtaining free technical assistance. So they can do that, certainly. You can hire a consulting firm to come in and look at your system and assess it and identify ways to improve operations. David Horvath and I are doing that now in Nebraska. We're looking at their systems and seeing where they could improve or streamline, but improve access for participants. So there are a number of different resources out there, and there are a number of different ways that states can look at their own self-directed waivers and identify areas that need revitalizing, remodeling, things like that.
Perfect. I want to jump back one more time to a term you used earlier in the podcast called budget authority. And I've asked a few of my questions pointed towards disabled and elderly populations, but you and I just came from a conference last week, a national conference for intellectually slash developmentally disabled individuals. And there's a whole world of self-direction out there for both children with a diagnosed developmental disability, which may include autism, for adults. We definitely have parents who are caretakers for adult children that we met last week on IDD models of participant direction. And those programs, I feel like budget authority, where the individual gets control over an amount of money, in theory, a Medicaid budget. And we've talked a lot today about hiring an attendant to come in the home to provide direct care. But we see a lot of what are called participant directed goods and services when it comes to intellectual and developmentally disabled plans of care and their budgets. And wow, what a lot of cool things you could do in that model. Could you say a little bit about the IDD models and what are participant directed goods and services in
Mm-hmm.
comparison to it's not attendant care. It's not even a person all the time.
Right, right. Well, what the Centers for Medicare and Medicaid says about budget authority is that it is the option to allow people to look at their individual budget and say, I want to spend X number of dollars on direct care, bathing, dressing, grooming, things like that. And then I want to spend the rest of my budget, my allocation, in a different way. Um, in the IDD community, we see that people are using their budgets for community inclusion, which is one of the requirements of Medicaid, is that a person with an IDD diagnosis has the ability to go into the community and be supported by the program. So what we're seeing is people are going to gyms, they're going to events, they're going to conferences, um, things that they're taking informal training courses. They're going to summer camps. That's particularly important for a person with an intellectual or developmental disability. So we're seeing that any item or service that promotes that individual's independence could be a permissible good and service. So, as I said, in Arkansas, they even within budget authority have this discretionary amount that they can give for usually transportation, sometimes for home delivered meals, things like that. And then they also can save up for a washer, dryer, microwave, things like that. So, budget authority can be as limiting as the state wants it to be, or it can be as expansive as state wants to be. And as far as people misusing, there, anything that is paid for by Medicaid has to be in the plan of care. So it has to be vetted between a case manager or service coordinator about, what do you want to save up for? What do you want to purchase? And how is this going to help you improve your independence? And particularly reduce the reliance on human assistance. So that all has to be vetted within the plan of care. So you can't go out and say, well, I'm taking a vacation to France with my extra money. That probably would not be allowable or even affordable in a budget. But people can really help themselves out with just not bathing, dressing, grooming, things like that. They can actually make purchases that improve their life and extend their independence.
Suzanne, as always, not a question you cannot thoroughly answer. That is why you have the nickname the godmother of self-direction. You've given a ton. You've been doing this work for a long time. So the last question of the day is simply why? Why are you so personally invested in this, and why have you spent your whole career dedicating your time and energy to it?
One could say why, yes. Well, I've always been in public service. And when I first learned about self direction, I thought, what a neat idea. When I get old and gray, which is I am, um, I and say I have some chronic illnesses that prevent me from bathing myself and doing the laundry and cooking for myself. Am I going to want a stranger coming in, not knowing what time they're going to be there, who's going to show up, what they're going to do when they get there, and what kind of power do I have over them to tell them what to do? And I thought, well, I really don't want that scenario. What I would like to do is I would like to self direct. I think if we think about it, we'd all like to self direct our own services. We would have control over the person that provides those most intimate details of our lives. So we, sorry, got distracted. So and then of course the stories that we were first told, just very dramatic stories about lives changing. I remember one, it was Miss Lily Brannon. um, she was living in her home, and it was public housing, and she had an agency come in and they never did anything right. So she would have to send one worker back and another worker back. And then she changed agencies and experienced the same thing. And Lord knows she didn't need help with bathing or dressing or grooming on weekends, and certainly not at nights. So she was one of the first that enrolled in our Independence Choice program in Arkansas. And she lived in her bed and only got out to go to the hospital and to um, the doctor's office. But she hired a person to come in during the day to help her out. Then she hired her son to come in and do grocery shopping for her. And then she hired someone that lived in the same housing as she did to come in and just take care of her on the weekends then when she needed things. So to quote her, she said, I like being able to have a say in who comes here and cares for me. It's important to get someone who's on the ball and can do the job. And I think that the stories have built over the years for me. And it's why I continue to support self-direction and really, really believe in it, because I think it is a natural progression of our age. It helps us out in our most vulnerable states, and it's very respectful to my independence and my well-being. So it just gives me a chance to continue to have power over my life, and I like doing that for other people too.
And there's just nothing else to say other than thank you for everything you've given, Suzanne, and thank you for your time today.
Great. I've enjoyed this. We should do it again.